Hello everyone. This is going to be Chapter 18, Part 3. We are slowly but surely on our way to becoming experts when it comes to the heart. So by now we should be familiar with the different chambers, the different valves. We should definitely be able to do blood flow through the heart, starting with the right side and ultimately exiting out of the left side. So be able to connect our pulmonary and our systemic circulation. And what we're going to do now is we're going to take a look at the electric component of the heart. What exactly is needed to induce an action potential? How do we get our individual myocytes to contract in unison? And obviously, how can we pick this up, or how can it correlate to the reading of an EKG? So without further ado, let's go ahead and let's get started. All right, so this is going to concentrate on sections 18.5, which is all about the electrical events of the heart. Now, what we see happening is that the heart as an organ can basically depolarize, meaning that it can increase the membrane voltage of its cell membrane, it can get excited, and it can ultimately contract without any stimulation from the nervous system. This is obviously the opposite of what happens with our skeletal muscle. Some of us might remember from our 2085 course that we had a whole chapter that talked about the neuromuscular junction and the fact that skeletal muscles can only contract when it receives a signal from the nervous system. And upon receiving the signal, we see that the individual muscle cells get excited, meaning that they depolarize, which ultimately can cause an action potential, and that in turn will cause a contraction to occur. The heart has the same ability to contract and relax. However, it does not rely on nervous system stimulation. Instead, what we see happening is that it has an intrinsic ability to depolarize and repolarize. However, it will receive input from the nervous system as well as other things like the endocrine system to help regulate its basal level, meaning at rest how many times the heart will beat per minute. The fact that the heart is able to set its intrinsic conduction system, meaning that it happens from the inside out, it doesn't require any external stimulus, is partly due to the fact that it can coordinate when all the individual myocytes and cardiac muscle fibers will contract and relax. This is partly due to the fact that it has access to lots and lots of gap junctions. As we discussed at the end of part 2, gap junctions are a way that the cells can link together, almost using like a hole punch format, where they can share cytoplasmic content such as different ions, including our sodium, potassium, and calcium. The other thing that we see is that the heart has an intrinsic cardiac conduction system, and what that means is that it has a system of cells that are able to detect the increase in membrane voltage. They're able to detect the depolarization, and they're able to distribute and coordinate when the next set of cells will depolarize, ultimately leading to one strong contraction of the heart that will start on the top by the atrium and that will continue on all the way down to the ventricle. To understand this fully, we might have to refresh ourselves a little bit when it comes to terms like depolarization, action potential, and repolarization. So those of us who recently did our 2085, this should be very familiar to us. And for some of us, it might be a little while, so it's okay. I'll give you a little refresher. Here at the bottom, I'm going to go ahead and I'm just going to draw a typical action potential, okay? And what happens with an action potential is that you're basically seeing how excitable a cell can get. And it's all across time. How long does it take? Excuse me. And then on the side right here, we're going to label it MV, which stands for membrane potential. So let's kind of back up a little bit. There are certain cells in our body that can stimulate their cell membrane to conduct an electrical current and thereby get the cell membrane excited, almost like you're using a battery to kind of send a charge. These are cells like the ones that we come across in our nervous system, like our neurons, and definitely our muscle cells. Now, in 2085, hopefully you can recall that you had chapters where you talked about how this excitement can be used in skeletal muscles to go ahead and get the muscles to do its formation of cross bridges, its sliding filament theory, meaning that the muscle will contract, and when the stimulus goes away, the muscle will relax. We're going to take that same concept of exciting a cell and we're going to apply it to our heart. There are obviously some difference between skeletal muscle and cardiac muscle, but at the core of them, both of them are able to be excited. And when they're excited, what we see happening is that their membrane potential, so how many voltages their membranes are reading, will start to increase, and eventually it will have to decrease to set itself back to its resting membrane potential. So what it reads when the cell is not being stimulated and when it's resting. Now, when you look at an action potential, or when we look at excitation of an electrically stimulated cell, we're going to come across three main words. The first word is depolarization. Here we go, depolarization. Now I'm going to write DEP right here because it's going to take me way too long to write depolarization. When you are depolarizing a cell, what you're doing is you are exciting the cell. And in order to excite the cell, you're going to have to increase its membrane voltage. Okay, so on my little chart right here, I see that it's starting to go up, meaning that I'm increasing my membrane voltage. And when I do this, then I'm in the depolarization step. Now, the easiest way to depolarize is to take sodium, Na, that's my little sodium, and get these ions to go into the cell. And as sodium is going into the cell membrane is getting super excited, so it starts to depolarize. And oftentimes, to maintain this increase in membrane voltage, we're also going to have to involve some calcium along the way. Calcium is going to be very important because it's going to allow us to actually get the cells to contract and relax. But we're getting a little bit ahead of ourselves. We basically need to increase the membrane voltage, get the cell nice and excited, and when we do that, we are depolarizing, and that's mostly because sodium will enter into the cell. At a certain point, the cell will reach its peak of excitement, and that is then when we have our action potential. And the action potential will often correlate with a response in the cell. In our case, the response that we're looking for is a contraction. So the cell is so excited that it will respond, and when it responds, it will go ahead and give us a contraction. Now, once you have your peak, your action potential, once you have contracted, then it's time for the cell to kind of come back to its resting membrane potential, to come back to rest where we don't want it to be contracted. So now we want the cell to kind of reset, and when it does things like that, it will, for instance, relax. When the muscle cell relaxes, we see that its membrane voltage starts to go back down to its original setting, and when it goes down, we call that repolarization. I'm going to write REP. You can see repolarization right here with number 3. Repolarization is when you lower the membrane voltage, when the cell becomes more negative because it's going down, when the cell is resetting itself, so it's becoming less positive, more negative, it's going back to its resting membrane potential. So you can see here on my curve, I'm going downward, back to where I originally started. And repolarization is extremely essential because it's going to allow us to relax the cell and put it back to its normal non-excitability settings. We like to call that the resting membrane potential. So at rest, what's the original charge that you would come across? In order to assist with repolarization, you will often involve potassium, K, and potassium will come out of the cell. And as it floods out of the cell, we see that the membrane potential goes down to where it originally started from. So if you want to excite a cell and it's electrically stimulated, now what you're going to do is you're going to get it excited, increase its membrane voltage, allow sodium to go into the cell, and this is then your depolarization. When you reach your peak, you get your action potential, which means you get the response that you're looking for. In our case, the heart will contract, and then when the heart is ready to go back to normal and relax, we see that it has to repolarize, reset, lower its membrane voltage back to normal, and that's going to involve potassium coming out of the cell. So let's apply our little spiel to the picture that's being provided for us right here on our slide. So let me go ahead and get my little red marker, and notice on the graph, once again, we are comparing time to membrane potential. And we see that we start off over here around negative 55 millivolts, and we see that the membrane voltage is going to start increasing. And as it's increasing, it's able to do so because when we take a look at our heart cells, we're going to talk about the fact that it has this thing called a pacemaker potential, which means that it has a batch of cells that are continuously able to induce slow depolarization. And as they start inducing depolarization, they basically recruit more and more cells to get excited. And what we see happening is that they start depolarizing. And when they depolarize, that means that the membrane voltage starts to increase, right? You see how it's starting to go up. And this is all due to the fact that we're going to have sodium entering into the cell. And as it's entering into the cell, right over here, opening of sodium, there will come a time where you reach your threshold. That's my little dashed line right here. The threshold basically is your point of no return, okay? You have now excited the cell enough that it will be able to reach an action potential. And oftentimes, especially when you look at muscles, we see that to be completely successful in inducing an action potential, in addition to sodium rushing into the cell, we're also going to need to get some calcium. So our calcium channels are going to open up, Ca are going to open up, and they're going to flood into the cell as well. And as they're doing so, it's going to allow the cell to peak by its action potential right over here. So this is where we're getting our response. The cell is going to contract, and when it's done so, it's time to kind of relax. So we see that our chart goes back down. This is going to be our third step, which is repolarization. And in repolarization, we see that the sodium channels shut off. We no longer use them. The calcium channels become inactive. We no longer use them. And we switch over to potassium. Potassium opens up, and potassium exits the cell. And as it exits the cell, we see that it repolarizes, and it will eventually return back to its resting membrane potential where it was before. And because we're talking about the heart, remember, there's no time for rest. We have to keep beating. So we see that as soon as it resets itself back to normal, it's going to utilize that pacemaker potential, and we're going to go ahead and go right back in to our depolarization step of going upwards, reaching our action potential, and coming back down into our repolarization. And your heart will continue to do this over and over and over again. And as it's doing these action potentials, it's correlating with the pumping and the contraction and the relaxation. And this is all due to the fact that we have lots of sodium, calcium, and potassium, and the cells are able to share these ions because of the gap junctions that connects their cytoplasmic content from one cell to the next. Now, the other thing, in addition to having a pacemaker potential, is that we see that we have a sequence of events or a sequence of cells that will notice the excitation and will able to distribute this depolarization and action potential throughout the entire heart, starting on top by the atrium and working their way over to the ventricles. So let me go ahead and just make sure that everyone understands. When you see this terminology, pacemaker cells, I want you to think about a group of cells that will initiate the heartbeat. And they're going to be able to initiate the heartbeat because they are the first group of cells that are going to go through the depolarization and action potential step. And once they go through that step, they will go ahead and spread their excitement. And then what we see happening is the sequence of events that we have shown on this PowerPoint. Now, your pacemaker cells are going to be located in what we like to call our SA node, our sinoatrial node. And the sinoatrial node is located in your right atrium. It is literally just a group of cells that are termed the pacemaker cells. It looks slightly different from one person to the next, but we know that all the cells in the heart are able to go ahead and induce an action potential, but we don't want them to work on an individual basis. We want them to contract in a very uniform, collective pattern, because if they do that, we'll be able to generate a lot of strength, which will then correlate to a strong heartbeat. So we need to control when these cells will contract and relax, and the job of that will fall on our pacemaker cells, which we find in our sinoatrial node, which is located in the right atrium. Once those cells get excited, the next stop where they spread their excitement to will be in the atrioventricular node, your AV node. And your AV node sits between the atrium and the ventricle, and it will then spread its excitement to the atrioventricular bundle. The bundle will start traveling down the interventricular septum, and it will start branching off to the left and to the right. And eventually, its final stop of excitement, the final part where this electrical current is being spread, will be by the Purkinje fibers. And at that point, we have completely stimulated the atriums, and we are now moving our way up the ventricles so that we can spread that excitement as well. Let me show you this from an illustrated aspect. All right, so here's my heart, and in yellow are going to be our little nodes, our areas of excitement. And notice right here, we're on the right-hand side. We are by the right atrium, and we have our little SA node right here. This is where everything starts. So that's where you're going to find your pacemaker cells. These are the cells that are collectively going to get excited, and when they get excited, they're going to go ahead and spread that message from atrium all the way down to the ventricle. So here on my sequence of steps, I see that I'm going to activate my SA node, and that is going to spread its excitement over to the AV node. Here's my little AV node. These are a cluster of cells that sit between the atrium and the ventricle on the right-hand side. And that excitement will then spread down the interventricular septum over to the AV bundle. And from the bundle, as it goes down the interventricular septum, it starts to branch out. So you have your left and your right branching until you get to the part where you curve to both sides of the ventricle. And at that point, you can see the excitement is going upward because it's trying to excite the entire ventricle. And when it does so, it does it through Purkinje fibers. Your book also likes to refer to it as subendocardial conduction network, which is perfectly fine, but the Purkinje fibers is also an acceptable, and it's actually an older way of referring to that particular excitation to follow. Now, for those of us who are looking at this slide and we're going, wait, what is happening? Why am I doing this? Remember that the whole goal of the heart is to act as a pump. And as it's pumping, it's allowing blood to flow over to the pulmonary system, over to the systemic system. So in order for it to be successful, this pump has to be in unison. It has to be a strong contraction followed by a relaxation to generate lots of pressure and to keep the blood from flowing. So in order for us to have a strong contraction, we have to look at our individual cells and muscle fibers, and we have to control when they contract, meaning we're going to have to control when they get excited. So you can, for instance, come over here to the little diagram labeled B, and you can see that what's going to end up happening is that the first place where you're going to initiate that excitement, where you're going to initiate that depolarization, is going to be by the pacemaker cells, which are located in our SA node. And as those cells start to get excited, the excitement will go ahead and travel over to your AV node. And when you get to your AV node, that's the part where your atrium, both on the left and the right-hand side, become completely excitable. They start to depolarize to the max. And when you depolarize to the max, that's when you reach your action potential. That's when you reach your peak, which means that the atriums will respond by contracting. Now, as the atriums are contracting, we see that excitement continues to spread down the interventricular septum, through the bundle, through the branches, and through the Purkinje fibers. And at a certain point, the excitement has spread down the entire length of the ventricle, which means that the ventricle will get excited, it will reach its action potential, and it will also contract. Now, it just happens that as the atrium contracts, the ventricle is getting excited, and by the time the ventricle is fully excited, then the atrium is on its way to relaxing and kind of resetting, and then it's the ventricle turn to go ahead and contract. And because it does this in a sequential order, we're able to follow the blood as it enters through the atrium, goes into the ventricle, and then exits the blood again, exits the heart again, excuse me, whether it's through the pulmonary arteries or through the aorta. So this little diagram, 18.13a, basically shows us how the excitement spreads, starting with your SA node in the right atrium, where the pacemaker cells are, because they're going to be the ones that initiate that, over to your AV node, down the bundle, through the branches, and then up the Purkinje fiber, also known as the subendocardial conducting network. And as it's spreading its excitement, it's basically inducing the whole depolarization, action potential step, which will lead us to contraction of the heart chambers. Obviously, that excitement will start to taper down when the heart needs to relax, and that is then when you have your relaxation, your repolarization step, which involves the movement of potassium out of the cell. All right, so let's take a look at this again. I know it's going to be a little redundancy for some of us, but that's okay, hang in there. So it basically says that if you want to generate an action potential in the cells that are able to contract of the heart, we see that what we need to do is we need to do some steps. And we'll take a look at this comparison between skeletal muscle and cardiac muscle in just a second. For now, let's take a look at how can I induce an action potential because I want my heart to start contracting and get excited. So the first thing we're going to do is we're going to increase our membrane voltage. So here you see from the heart, that means that we're going to go from about negative 90 millivolts to 30 millivolts. So we're going to have to increase our membrane voltage. We're going to have to get excited. And the way we're going to do that is by allowing sodium to enter into the cell. Don't worry about memorizing these numbers. That's something you can easily look up. What I need you to know is that the first step of action potential is depolarization. And I need you to know that depolarization means that I'm increasing my membrane voltage. I'm getting excited, and that's because sodium is entering the cell. As the excitement starts to spread, eventually you reach your threshold, and that means that sodium is also going to be assisted by calcium. All right, and often what we see is that it's okay for the sodium channels to start closing, but because the calcium channels are still open, it's going to prolong the depolarization or the excitement step. The longer the calcium stays open, the longer the depolarization step will take. And the reason this is so important is because it starts creating what we call a plateau. This plateau or length of time that the cell is depolarized is what allows for the contraction of the heart to be nice and smooth. On the other hand, and this was mentioned on the slide previously, the part that I told you we would get back to, if we compare the action potential in a skeletal muscle, we see that there's no plateau. There's a quick increase and then there's a quick decrease. And that then leads to the muscles twitching. In fact, when you look at your skeletal muscle, so if you look down to your fingers, if you make a fist and then relax it, you're seeing a smooth contraction and relaxation. But if we were to zoom in, we would see that it's the accumulation of thousands of twitches that work in unison to get the contraction and relaxation. The heart does not have time to twitch. We don't want that. We want to have a strong contraction and relaxation. So what we see happening with the heart is that oftentimes the calcium channels will stay open longer, which will allow it to reach a plateau of excitement. Once the action potential has passed and the heart has contracted, which was our ultimate goal, now it's time to reset. So what we're going to see happening is that the calcium channels are going to close, and we're going to go ahead and switch over to our potassium. Potassium is going to come out of the cell, and as it's coming out of the cell, we call that an efflux. We see that it repolarizes the cell back to its resting membrane potential. so back to where it originally started. And when it repolarizes, that means that I decrease my membrane voltage. So I relax my cell, I decrease the membrane voltage, I'm going back to my resting membrane potential, so where it started with, and this is all due to the fact that potassium is coming out of the cell. Now, if this was a skeletal muscle, that would mean that that's where the story ends, because skeletal muscle has to rely on nervous stimulation every time it wants to do an action potential. On the other hand, your cardiac muscle doesn't have to wait for nervous system stimulation because it's able to trigger action potential intrinsically, innately, so from the inside itself. And because it has that pacemaker potential that you saw in the first few slides of this part of our lecture, it will go ahead and as soon as it has repolarized, it will start its depolarization step all over again. And that then is how we explain why the heart is consistently beating. And now also you're able to explain that that initiation of heartbeat, that pacemaker potential, is started by the pacemaker cells, which are housed in the sinoatrium node of the right atrium. And from that SA node, they will go over to the AV node, which will go down the bundle and the branches, all the way down to the Purkinje fibers, exciting from atrium all the way down to the ventricle. So here are just some quick comparison. I've said many of these already in some of the slides, so let's just take a quick look. It says the difference between the contractile muscle fibers, between that of the heart and the skeletal muscle. In the action potential in skeletal muscle only lasts a few milliseconds, whereas that in cardiac muscle, remember how we talked about that plateau? Because of the fact that the calcium stays open longer, it lasts a little bit longer. So that way you don't get a twitch, you get a strong contraction. Same thing goes here. Because the action potential is short, that means that the contraction in the skeletal muscle is that little twitch where it's nice and smooth in the cardiac muscle. You don't have to memorize the times of these. Just know that there's a plateau in cardiac and that cardiac has a nice and smooth contraction, whereas skeletal muscle is really quick and it generates twitches. So right here it emphasizes that. It says the benefit of a longer action potential and contraction is that it allows for sustained contractions, which means that we have enough time to get rid or eject the blood, whether it's from the atrium to the ventricle or from the ventricle into the pulmonary arteries or the aorta. And then obviously longer refractory periods, that's when the cells are all resetting themselves, getting ready for the next contraction. That is useful for preventing tetanic contractions, which are these like shortened contractions almost when the muscle is spazzing. All right, so here's just another diagram showing you your action potential with your cardiac muscle cells. So once again, I know it's going to seem a little redundant, but we definitely want to make sure that we understand what these terms are creating. So if you go ahead and take a look at the blue graph, it's going to show you the depolarization because sodium is flooding into the cell. And then we see that we have our nice little plateau for our action potential. That's due to the fact that calcium continues to slowly flow into the cell, keeping the cell nice and excited. And then eventually it's time to reset, step number 3. That's going to be our repolarization, which is going to be due to the fact that now you have potassium doing an efflux or an exit out of the cell. And that blue graph of going up, plateauing, and coming down is going to correlate with the muscle fibers responding by generating different types of tension, which is then what we correlate as having a contraction because the action potential got the cell so excited that it responded by contracting. And when the action potential goes down, then we see that the tension starts to diminish, and that then correlates with a relaxation step of the cells. All of this can be picked up in an electrocardiogram, an EKG or an ECG. Sometimes they have it spelled with a K because that's the German spelling. So that's the one that I kind of am familiar with, the EKG, but it's the same thing as an ECG. Basically, what you do with this cardiogram is that you have your patient preferably lie down and you hook them up to different leads, different electrodes, and it's able to measure or detect the voltage changes that are occurring in the heart. The reason you tend to have your patient lie down often is because you don't want to have an interruption of the electrical signals of the skeletal muscle. You only want to concentrate on the cardiac muscle. And that's why there'll be EKGs that will have 3 leads, some will have 6, but ultimately you want to have about 12 of them to get a nice little picture of the electrical activity from the atrium all the way down to the ventricle. Now, one thing you also want to keep in mind is that when you're looking at the reading of an EKG, you're looking at the electrical current. So you're looking at the whole depolarization, action potential, repolarization stage. And what you need to keep in mind is that that excitement of increasing the memory voltage will lead to the muscle contracting. And when that excitement goes down, so when you're doing your repolarization, that will ultimately lead to the muscle relaxing. So you need to get excited and then you contract, and then you need to relax, and then you then you need to do your repolarization, and then you relax. I'm going to repeat that sentence because I confused myself when I said that. So my apologies. When you're looking at an EKG, you're looking at the electrical current. So when you see that, you're seeing the depolarization, the excitement, and in your mind, you have to remind yourself that that is going to lead to the muscle contracting. And then when you see that the graph goes down and it's becoming less excitable, it's doing its repolarization, I want you to remind yourself that that means that my muscle cells will respond to the repolarization by relaxing. And obviously, we're going to work our way through a bunch of different examples so that you can have a more comfort level when it comes to EKGs. Here are the main features, which I know for some of us mean nothing at all, but let me introduce their names and then I'm going to go ahead and I'm going to show it to you in some pictures. A typical EKG reflection will have, oh my goodness, I am so bad at drawing right here. We'll have a small little wave to start everything off. It will then have a larger peak, and then it will have another small little wave. The first wave, and I know my picture is horrible, there are better ones coming up, I promise you. The first wave is called the P wave. And the P wave is going to take a look at what's happening within my pacemaker, so the SA node, which means it also takes a look at what's happening in the atrium. And remember, we're doing electrical currents, so that means we're going to take a look at the depolarization or the excitement of the atrium. The next peak right here is going to be our QRS complex, and the QRS complex, you're going to notice, is a lot taller than the P wave, and that's because it has to do with a larger area of excitement. It has to do with the ventricular depolarization. At the same time that the ventricle is getting excited, the atrium is resetting itself because it has already responded, right, through the P wave. So that signal of the atrium repolarizing is also embedded in this QRS complex, but it's often lost due to the fact that the ventricle is so much larger than the atrium. The third little bump, this one right here, that one's called the T wave, and that is all about the ventricle repolarizing or resetting itself back to resting membrane potential. So we're going to start on top and work our way to the bottom. P wave is for the atriums, QRS and T are for the ventricles. And I'll definitely give you more examples and a different explanation as we move through some of the pictures that are going to head our way. When you're reviewing your EKG, so when you're a little bit more comfortable, I want you to come back to this slide and I want you to take a look at some of the intervals. So these are kind of like different sections. Anything from P to R is going to basically mark the beginning of excitation of the atrium all the way to the beginning of the ventricle getting excited. So now you're just kind of marking off when one gets excited versus the other. So the top chamber versus the bottom chamber. From your S to your T, that's basically when the ventricle is completely depolarized. And from your Q to your T, that is when the ventricle goes from depolarization all the way to repolarization. And I know for some of you right now, you're looking at it like, what is she talking about? This doesn't make any sense. Don't worry, I just wanted to introduce the main features. We're going to go and switch over to the picture mode so we can see the clear difference between the P, QRS, and T feature of an EKG. Okay, here we go. Isn't this illustration so much better than mine? All right, so when you're looking at an EKG, you're basically looking at the heart getting excited and relaxing, and then we correlate that with a contraction and a relaxation. So we're measuring the electrical currents, the depolarization, the action potential, and the repolarization. And when you look at one heartbeat, we usually, in a very healthy person, we want to see our appearance of our P wave, our QRS complex, and we want to see our T wave. So those are the three things that I was mentioning to you previously. Those you definitely want to see make an appearance on your EKG. Now let's come over here to our little illustration of the heart, and we're going to see that they marked for us where everything begins, where the excitement begins, and that's going to be with our pacemaker cells in our SA node. So what we see happening is when this node fires off and gets excited, it will correlate with the start of the P wave. And the P wave will go up and it will go down. And it turns out that during the time period of the P wave, what we've done is this entire atrium, both on the right and on the left side, has had an opportunity to depolarize, meaning to increase its membrane voltage, to get excited because calcium and sodium have been rushing into the cell. Now we're picking up the depolarization, and because we're picking up the depolarization, we also know that at the end of the depolarization, how is the atrium going to react? Well, it's going to contract. So at the end of the P wave, even though we're not picking it up on here, we know that the end of the atrium depolarization will lead to the action potential, right? Which means that the atrium will contract. Now, as this is happening, we see that the excitement has gone from the SA node to the AV node, and we can't stop it, right, because it's going to keep spreading. So we see it going over to the bundle, through the branches, over to the Purkinje fibers. And that travel point into the ventricles and beyond is what's being picked up in our QRS complex. So this higher peak has to do with the fact that the ventricle is a lot larger, so it's going to give a stronger signal, and it correlates with the ventricle depolarizing itself. So the ventricle is getting super excited, it's increasing its membrane voltage, and at the end of the depolarization, at the end of QRS, it's going to go ahead and it's going to contract. Now, at the same time that the ventricle is contracting, what's happening with the atrium? Because the atrium was contracting beforehand, right? It was contracting right over here, a little bit after the P wave. Well, the atrium, if it's contracting, that means that the next step is for it to relax. So at the same time that the ventricle is depolarizing, the atrium is repolarizing and relaxing. Because the atrium is smaller, that signal is lost within the QRS complex. But we know, based on our knowledge of the sequence of events and how blood flow, that a depolarization is followed by a repolarization, which is followed after a contraction to a relaxation. Once the QRS complex has been done, then the entire heart has been excited, which means that what we need to do is we need to get our ventricle to repolarize so it can reset, and that is then picked up by the T wave. Once that's done, then you have a complete heartbeat. You'll have a little line that's straight, that's its little plateau. That's kind of when everything kind of resets itself so we can start all over again. And you can see all together, it takes about 0.8 seconds. So that's why I keep telling you that on average, you have a heartbeat every I say 0.75, but some people like to round up to 0.8. That's fine. So you'll have your heartbeat every 0.8 seconds. And your heart rate is going to involve the P wave, which means that my atrium gets excited, it depolarizes, and it contracts. My QRS complex, which is that my ventricle depolarizes, it gets excited, it contracts, and at the same time my atrium is repolarizing and resetting itself, it's relaxing. And my last item I pick up is my T wave. My T wave is when my ventricle repolarizes and relaxes itself. And then we have a slight little plateau, and then we go right back over to the P wave, QRS, and T wave. And we're able to do this over and over again because remember, we have our pacemaker potential. We have the group of cells in our SA node that just continuously depolarizes and gets excited. And that is then what initiates the heartbeat from the top towards the bottom of the heart. So from the atrium all the way down to the ventricle. Take a look at this picture. This one I like because for those of us who are still trying to piece together how what's happening in the heart is corresponding to our EKG or ECG reading, we can see happening here is that what they've done is they've used some color coding. So if you start on top, you're going to notice that using orange, they're indicating an area that is depolarizing, so an area that's getting super excited, all because of the SA nodes firing off, and that's all happening within the atrium. And then notice how it's being correspond to the green section on your EKG. So as the P wave forms, that is going to go ahead and indicate the fact that my atrium is depolarizing, all due to the fact that the pacemaker cells are the ones that kind of pick it up. By the time the entire atrium is depolarized, we are now towards the tail end part of the P wave. And what ends up happening is that the depolarization will result in an action potential, which will then mean that the atriums will contract. Next stop is for the excitement, the depolarization, follow the yellow, to travel down the interventricular septum through the branches and the Purkinje fibers. And as it's doing that, look what's happening here on number 3. We see that in green, our QRS complex starts to form. So our ventricle is depolarizing. Now notice on your illustration that we now have a new color. We also have red. Red is going to indicate repolarization, so resetting. So we see that while the ventricle is depolarizing, the atrium is repolarizing. And that's why I was telling you that the atrium is starting to relax while the ventricle is getting ready to contract. And you can see the depolarization of the ventricle is complete by the time you reach the tail end of the S wave right over here, or the S section, I should say. And at that point, the ventricle will respond by contracting. And then last thing that we need to do is we need to get the ventricle to relax, to repolarize. So notice how the yellow area in step 5 and 6 is quickly replaced by the red coloring of repolarization, which means that the membrane voltage is going back down, the ventricle is going back to its resting membrane potential, and as a result, the ventricle will relax. And then we have a short little break, and then we start all over again. And it just keeps going, starting with the P, then going to the QRS, and then finally the T wave. Keep in mind that you are picking up the electrical readings, and after the electrical event has occurred, then is then when you'll get the muscular reaction of contraction and relaxation. So for instance, let's say we come across a question and it says, when does the atrium contract, right? So it says, when does the atrium contract? Is it going to be before the P wave, during the P wave, or after the P wave? So when does the atrium contract? Before, during, or after the P wave? Now keep in mind that the P wave is telling us our electrical excitement, and it's going to take us the entire P wave to get the entire atrium excited or depolarized. So that means that you're going to have to wait till after the P wave for you to have enough excitation for the atrium to contract. Same thing goes for the ventricle. The ventricle will contract after the QRS complex, and the ventricle will relax after the T wave. So please keep that in mind, because the EKG or ECG is basically corresponding to the electrical currents, and we are then lining up when the contraction and the relaxation of the muscle cells are occurring. Here is a look at what we like to call a sinus rhythm. A sinus rhythm is a normal EKG, so about 75 beats per minute, one every 0.75/8 seconds. And when you look at your diagram over here, or your EKG reading, you should easily see the continuation of the P, the QRS, and the T wave. And you can see them, they're just going in sync. Nice format, so your patient is nice and relaxed and the heart is beating at a normal rate. And this particular sinus rhythm is due to the fact that, as I mentioned to you before, the nervous system will communicate with the cardiac cells and will decide what your resting heart rate should be. And that will have to depend on things like your body size, the amount of blood, and your overall health. How about this one? Now, don't read the text just yet. Just come down to the picture. Take a look over here. You can obviously see the QRS complex. That's the larger one. And you see your T wave, but there's something missing, right? We're missing the first part. We're missing our P wave. Where did it go? So it says right here, the P wave is absent. This is what we like to call a junctional rhythm. Now, what would this indicate? Well, if there's no P wave, that means that we're not detecting the electrical current that's happening from your SA node. So most of the time, that means that your pacemakers in your right atrium are no longer initiating the heartbeat. Now, usually what we see with these patients is that because the cells are still able to contract and relax by themselves, the control or the initiation of the heart rate will fall to the next node. So as you can see right here, it says the SA node is non-functional, which means that your AV node, your atrioventricular node, will take over the initiation of the heart rate. What we do see happening though is that usually the heart rate will lower itself per minute because the contraction isn't as uniform as it normally would be. So instead of having about 70 beats per minute, we see that the resting heart rate will be between 40 to 60 beats per minute. Now, before we take a look at this heart block, one thing that I want to mention to you is that if your patient comes in and they don't have a P wave, you often want to consider the age of the patient and their activity level, because lowering the heart rate per minute will severely reduce the amount of energy they're able to accumulate. Now, usually with elderly patients that are not very mobile, it's acceptable. However, if you're looking at a young patient and we see that their pacemaker cells have shifted and your AV node is taking over, oftentimes an artificial pacemaker needs to be put in, and that just basically involves the electrical stimulation of your AV, of your SA node from an external source so that the heart rate can be initiated on the top part of the right atrium, thereby increasing the heart rate. Now, there has also been cases where you have a patient comes in where their SA node falls out, which means the AV node will take over, and then the AV node falls out, which means that it's left over for the interventricular septum, the node, the branches, and the Purkinje fiber to initiate the heart rate. Now, when this happens, the resting heart rate will drop as low as to 30 to 20 beats per minute, which is definitely not enough to sustain life, which means that at that point you would definitely want to go ahead and put in a pacemaker so that you can increase your beats per minute. I should say it's definitely not enough to maintain quality of life. They're not dying. They're just very weak and they're not able to do a lot of activities. My apologies. All right, let's go back to this picture. So this one is showing us a second-degree heart block. So here we have that the AV node fails to conduct some of the SA notes. So as a result, what we see happening is that there are more P waves than QRS complexes. How is this possible? Well, because we see that there is a blockage in communication between your SA note and your AV note. So that means that your pacemakers are still firing off. So you're able to generate your P waves. But there is a miscommunication and not all the signals are able to activate your AV node. And because the AV node is not activated consistently, that is then why you start missing some of your QRS complexes. And that's why they call it a heart block, because the electrical current can't seamlessly go from your SA to your AV node. How about this one? This one is called ventricular fibrillation. Now, ventricular fibrillation is usually what you see when your patient is suffering from a heart attack. A heart attack or a myocardial infarction usually means that somewhere or another the blood supply to your individual cells in the heart is being cut off. And when the blood supply cuts off, that means that the electrical current is not able to seamlessly go down its regular path of pacemaker in the SA to the AV, down the bundle through the Purkinje fibers. So instead what we see happening is that we lose control of that unison contraction and relaxation. Now the individual heart cells are still able to contract by themselves, but if they lose communication with the pacemaker cells, we see that they'll contract at a very random pattern, and this will be picked up by the electrical activity showing up as very disorganized. So here on your diagram, notice how you don't really see a P, a QRS, but the cells are still beating or contracting, and that's then what's being picked up. The problem with this is that it's not generating enough of a contraction that it will allow for adequate blood flow to occur. So this could be very detrimental to your patient. So as you can see, it says right here, seen in acute heart attack or after an electric shock. So what can we do to get the heart rate to kind of reset itself and once again in unison create the P, QRS, and T wave? Well, you go get the paddles. You get a defibrillator. And that's then the defibrillator is what you see happening whether you've done an internship at a hospital or you just watch your favorite medical show. When they get the paddles and they give an electrical shock to the patient, when they're doing that with a defibrillator, it allows the cells to kind of halt, reset, and it allows the pacemaker cells to take back over control. And when they do gain control back, we then start seeing the P, QRS, and the little T wave forming again, indicating that there's a stronger contraction force and that the heart is able to restore blood flow either to, both to the pulmonary circuit as well as to the systemic circulation. That is my final slide for the EKG/ECG. Go ahead and take a look at it. There are no pictures on our exam, so please make sure that you're able to describe the P, QRS, and T deflection. And obviously, if something comes up, please keep in mind that I'm always available for you through email, and I highly encourage you to use your discussion sessions as well. All right, we have one more part to do for chapter 18. This one is a very detail-oriented chapter, so it has multiple sections. So whenever you're ready, come on over and listen to the last part, which is going to take a look at cardiac output, which basically entails that we're going to add a little bit of math to our discussion, and we're going to take a look at how much blood actually flows out of the heart per minute. All right, I'll see you for part 4.